continuing education classes, incorporating the latest technology and techniques from all over the world. He was recently featured in the New York Times article on his use of silver diamine fluoride. Welcome, doctor. The mic is yours now, and you can start sharing your screen.
Hello, how are you? All right, thanks for doing this. I don't usually lecture very much, so hopefully I'll be able to convey whatever I'm trying to put across. I do have a PowerPoint that I'll share on the screen in a minute. Generally, when I try to teach, it's more usually hands-on and more give and take, but I'll hopefully be able to convey whatever I can teach, you know, in the next little while. Let me just see if I can figure this out. All right, here we go. Give you 1 minute, sorry about that. All right, hopefully that works. So I call this lecture Pediatric Dental Sandwiches because in general, I try not to focus so much on the big picture and everything, and I try a lot to cut things into little parts. So it makes it a lot easier for me and for my patients. Instead of just looking at the entire picture, I try to look at my job as a bunch of little parts, and I also oftentimes try to sandwich a lot what I do. So with pediatrics, different than with adults, you don't have a lot of time to do what you want. You got to work quickly, and for me, it's always a lot easier to try to make sort of little steps instead of one big picture going on at the same time. So for me, when I was in residency, we used to call the papoose board the pedo burrito because it looks a little bit like a burrito. So for me, I'd rather a sandwich than a burrito. I like to put sort of one step at the beginning, treatment in the middle, and another step at the end. So that way, instead of trying to make the whole process a more clinical process, we try to take the focus actually off of the clinical part of it and push it more onto the more fun parts of the appointments. I do a lot of magic tricks for my patients, and that's why a lot of people know me. Personally, I'm not really into magic tricks that much, but I did learn a few magic tricks and it works beautifully for my patients. So for me, it was just a lot better to try to sort of sandwich fun magic tricks between, you know, all the work that we do. So that way we're not focusing all on the scary dentistry part of it and more focusing on the actual fun parts, the magic tricks, the jokes, the prizes. So we try to take away a little of the clinical aspect of dentistry for kids because for me as a pediatric dentist, I feel like there's two parts of our job. There's the teeth part where we have to fix the part, you know, the teeth, and in that the techniques for pediatric dentistry are not very complicated, but working with the actual patient is what makes it a lot more of a challenging situation. So for me, this is the advertisement when they sell papoose boards. This is really what kids look like more often when they're in a papoose board. So for me, we try very hard to avoid any of this kind of techniques because sometimes even though it's necessary, there are often times where we can avoid it. So in my practice, we generally don't restrain patients. Patients are usually not crying. We don't sedate patients. So we really work really hard on all the techniques around it. So that's what I'm going to be speaking about today. This is just a picture from where I started the process. That's me when I was at the dentist. I still don't like going to the dentist, so I definitely understand what my patients are going through. And that's, I think, part of the reason why I was able to come up with these different techniques, because I knew what I didn't like as a kid. And so I try as much as possible to avoid those type of things. So for me, the number one thing that will help any of our patients is start as young as you can. If you can get a dental home by age 1, which is what we really try to push here in the US, pediatricians oftentimes recommend starting the process at 3. But oftentimes, if we can get them a lot earlier, we can start the process off more of a positive note, because if a child starts the process at 3 and they already have full mouth cavities, they're already starting off on a negative step. So we really want to try to get them in as early as possible. My feeling is, in theory, if I got every patient in by 1, most likely we wouldn't have any patients that were scared of the dentist, because regular visits, we'd be able to catch what we needed early, and patients wouldn't be going into more difficult processes. So generally, I try to really, really focus and push on trying to get patients into the dentist by age 1 if possible. We don't want to wait until there's more of an issue. And that's something that I find is really important to discuss with pediatricians and also with parents. Sometimes we would also recommend, if possible, to sort of make a class for new parents, because that can also just keep them educated. A lot of times parents don't even realize that children get teeth that young, and if they do get teeth that young, you even have to do anything about it. So the number one behavior management technique for me is try not to need behavior management. So if you can prevent decay, which is definitely preventable, that's always a much better option. With pediatricians, oftentimes they don't know as much about the teeth as we do. So oftentimes what will happen is, this is just a joke that I found online. Oftentimes pediatricians don't really understand the oral cavity as much. We've had cases where a patient bites his lip and goes either to the emergency room or to the pediatrician, and you know, they come back with a diagnosis of an allergy to something that was used in the dental office or an infection, and they're put on antibiotics, and we know as dentists that's not really the case. What's really going on is a lip bite. So really, pediatric dentists should be sort of the first step, and educating the pediatricians about getting them to the dentist early is really, really important. So starting that process is really, really an important, sorry about that. Starting the process in sort of a sandwich part is that really what we're trying to do is cut the appointment into 3 parts. The pre-appointment, which is the beginning parts of the process, during the appointment, which is what we're doing, which we're really trying to avoid as much as possible. We're really trying to keep most of the focus on the beginning parts and the end parts. We don't want to keep the clinical part as the focus. So for me, the sandwich is trying to keep the pre-appointment something that's fun and exciting, the appointment itself something short and sweet and something really, really quick, and the post-appointment something also that they'll enjoy and remember. So we oftentimes sort of finish an appointment and then the patient leaves and they go home. But for me, in our office, we generally end the appointment with either a balloon animal, which my associate does really beautifully, or with a joke. We always do prizes, magic tricks, whatever we can do to try to make them remember more of the last thing we did versus what was done clinically will definitely help in the future. Because if we can start things on a positive note and end things on a positive note, even if the middle of it wasn't as exciting, which we still try to make happen, even if it isn't as exciting, it's still something that they'll sort of not focus on as much. So instead of looking at sort of the big picture, they have a dental issue that we have to deal with and then fixing the dental issue, we want to look at the small picture in that there's still a kid who's attached to this tooth, and we really, really need to make sure that we're focusing on all the whole process to keep it as a positive process. So with a pre-appointment, what I find is that getting to know the patient before you do any work is really, really important. In our office, pretty much as a rule, we don't do dental treatment on a first appointment. Sometimes we'll do cleanings and exams, typically, but we don't do actual dental operative work at a first appointment because in our office especially, we do get a lot of patients that have been to other dentists and have had more difficult times. We do have a lot of special needs patients as well, and we really want to build a trust and a relationship before we even start anything. So generally, we usually recommend what we call a meet and greet. So we meet the patient, we hang out with them a little while, show them some tricks, so that way they can realize that we're a little different possibly than some of the other medical professionals that they've seen. Most times when patients have already been to our office, they've previously either seen another dentist or they've been to a pediatrician and gotten immunizations or different kind of treatments that they already associate negatively with a more clinical feel. So what we really, really try to do is try to kind of disconnect that negative feeling from our office. So meeting in the waiting room is a really important thing. In our waiting room, we have a fish tank and tablets and TVs and games. So that way, once they come in, they're already distracted from the clinical feel and see more of an exciting feel. I mean, even in our background, you can see this is just our background in our room. It's not a fake computer background. We just try to make the entire process a more exciting process. Another tip that I often find would be really helpful is that if a patient comes in and they're already nervous and they're there with a sibling, I try to keep the focus even off of the patient a little bit, and we discuss it with a sibling who may not be as nervous. So we can do a magic trick for a little sibling, older sibling, and then the younger sibling who's nervous oftentimes will just kind of come by and see what's going on instead of going straight at them. where they may be a little bit more nervous. We want to try to keep the focus off of anything that makes them nervous. So meeting them in the waiting room with something exciting like a prize or a magic trick, or, you know, joking around a lot. In our office, the stupider the joke is, the better the joke is, because, you know, at that age, they don't need anything exciting. They just need a stupid joke, something that will make them smile a little bit. And as soon as you have them smiling, you can kind of get the focus off of the more scary parts a little bit. Here, this patient actually was about 3 years old when he came to our office, and you can see in the top corner over here that he was terrified. He was hiding under his brother's legs under the table, and he barely would even look at me when he first came in. So we worked really hard, showed him a lot of magic tricks, showed him a lot of toys. He liked the turtle that we had, so he held onto the turtle, and little by little, we were able to gain his trust and kind of work our way to getting him into the chair. Oftentimes, it's a little difficult to get these patients into chairs, so if you can convince them beforehand that you're somebody that can be trusted and build a relationship with them, it makes life a lot more simple for them and a lot more simple for you because of that. So I have been asked very, very many times, how do you have so much time to spend with them? So really, we don't have that much time. We don't schedule much longer appointments than most offices. Typically, a new patient appointment is either a half hour or 40 minutes, and operative appointments are the same. Generally, the time that we spend up front, I find we save afterwards, because the more we can build trust, the faster things eventually will go. So you really want to try to disconnect any previous traumas, any difficult situations, any negative experiences, and try to move your way towards teaching them that you're a safe environment and a person that they can trust, who's going to make it a lot easier for them. So with this patient, now he's, you know, a much less stressed out patient, and now we can work much faster versus if we would have pushed things initially, it makes things a lot harder later on. So this is just a joke that I found online when I was in residency. Again, the stupider the joke is, the better it is for the patients, and you can find any jokes that, you know, work for you. A lot of the jokes that I have only work in English language because a lot of our jokes are based on wording. But what I find is that even a kid who's very stressed out, if you can make them laugh, it kind of melts away the stress a little bit. So really important to try to joke a lot and laughing. So I do have in this lecture a lot of videos, because for me, most of what I do is not based on studies and based on books. A lot of the specialties in dentistry are more quoting statistics and quoting studies. Most of pediatric dentistry, or a lot of it at least, doesn't have that. There's not a great way for me at this point to study, you know, how my patients are doing versus somebody else's patients who are not doing magic tricks. But from my point of view, I see it more of a sort of an overview versus like a purely technical situation. So I don't have any way to say, you know, do these 5 steps and this is the outcome. What we try to do is have as many tools as we can get in terms of keeping kids happy with jokes, prizes, balloons, magic tricks, toys, all those kind of things, together with non-invasive dental techniques, which I'm not really going to discuss much today. Today, we're just going to really discuss the things before the clinical aspects. But putting all those things together gives you a much bigger range of options when we have patients in the chair. So you're not just stuck with, you know, my patient's coming in, this is what I need done, this is what I'm going to end up doing. You really want to try to work on things sort of together. So I do see that somebody asked a question, how do you handle burnout in dealing with children patients between your tight schedule? It's a very good question. I actually have 6 of my own children, and I've been around kids my whole life. So I find that an important thing to do to avoid burnout is to not make it personal. I've had friends who work in the same field, and oftentimes we hear different situations where a patient starts not cooperating for a certain situation, and the dentist gets mad at them. So for me, the way to avoid that is twofold. Number one is realizing that they're children and they're not trying to cause trouble. Most of it is based on fear. There are patients that definitely do have behavior issues, but I try to make it not my behavior issue, so that I understand that it's a behavior issue and I have to figure out a way to work around it, but it's not my job as a pediatric dentist to parent the child or teach them how to behave other than for what I need. So I do find that especially with the children, they do oftentimes act up, mostly out of fear, because they don't really know how to act, you know, interact with the fear. They don't know how to explain what their fear is. So instead, they just act out. So what we really, really do is we try to keep them, as happy as possible, and understanding also that they're children and children sometimes act out. So the most important thing that I find is making sure that you don't internalize that stress. It's not your fault that the patient is not acting how you want them to. So you don't have to start getting stressed, because what happens is when a patient senses your stress, that's just going to keep that process going and keep it going where they're stressed and you're stressed at the same time. And it generally doesn't work out as well that way. So I'm just going to show you the next slide as we go. One second, sorry, I'm just going to close these questions a second. Now, so this is a video actually.
So you go up. Ready?
And this is just something typical
in there?
Do in the waiting room.
No, watch. Color with me. You think that would work?
You already see on her face.
Yeah, should we color in the pictures?
At first, as soon as she sees the beginning of the animation, she's already smiling, a little more comfortable.
You make crayons?
With these magic tricks,
You do it?
try to get them interacting with me at the same time.
1, 2, 3.
You can make her part of the process.
How do you do that? Okay, take them out. Ready?
Process as well. So it makes it a little more exciting because she's watching something
You hold
outside.
them. Don't drop them. Close. You got them? Alright, we're gonna have to color in the pictures. Are you ready? Watch. See any colors in there? Throw the colors in.
How did I do that?
Because you're a magician. Are you a
That
magician?
kind of face is what we're looking for.
No.
As soon as they see
It's
that,
more
it's
spiritual.
less of an interest and more of somebody who's exciting and fun. Somebody did ask me how I learned my magic tricks. I actually learn them little by little. I don't have a lot of places where I specifically learn them from. I just over the years have done whatever research I can on YouTube, and my assistant goes to magic stores and I find things on Amazon. So it's really just a mix of as many things as I can find. I'm going to continue just with the PowerPoint just so I can get to more on the information, and at the end I'll try to answer more of the questions. So at the pre-appointment, pretty much at the beginning of the appointment, there's something that we have in our textbooks called the functional inquiry. And the functional inquiry is basically questions that you can ask to get more information about your patient. So if you get the information beforehand, then you already know what you're dealing with. You're not just kind of stuck with a patient that you don't know anything about. So what I generally do, I don't use this specific functional inquiry. I kind of cut mine down a little bit so it's a little faster, but the point of this is to get a little information. So from the main one, number one, you want to know how the child has dealt with things in the past. So for me, usually it's asking how are they at the pediatrician, because if they're really impossible at the pediatrician, we can't really expect that they're going to be super happy to be at the dentist. The second thing is if the patient thinks that something is wrong, which is a very important fact, because that comes back to starting things early. If you already are at the point where the patient's in pain or swollen, they already feel like something's wrong, they're already stressed out. So if you can get to them before there's pain, get to them before there's any major issues that they can already feel, you don't have to worry about it as much. Another thing that we realize a lot is that there is a correlation between the parent's anxiety and fear and the patient's anxiety and fear. So generally we want to know from the parent, and oftentimes as you gain experience, you'll know from the parent already how they feel personally about going to the dentist, because they're going to be kind of conveying that information to their child as well. And the next thing is, how do you feel the patient is going to do? So the child is known by their parents a lot more than you know them. So asking the parent how you think the kid is going to do is often very helpful also. I do feel oftentimes that as a pediatric dentist, we have two patients at the same time. We have to deal with the parents' expectations and what's going on, and also the patient's expectations. My wife is actually a labor and delivery nurse, and she always tells me that she has two patients also, because she has, the mother and the baby. And I feel like we have a similar thing where we have two patients, and we both have to deal with two different people at the same time. So my shorter version is, number one, how do they do at the pediatrician, and have they been to a dentist before, and how do they do? Number two, is the parent nervous about going to the dentist? And number three, what I find is important that is missing on the other questionnaire is specific sensitivities that patients have. Because again, as an adult, you can deal with things that you don't like to a certain extent. So even if you don't like how something tastes or how something smells, you're not gonna have a major reaction to it. But some children do have major reactions which are much more exaggerated to taste, smells, sounds, textures. So there's a lot of things that we may not expect that a patient's going to be nervous about or really stressed about that actually may be the deciding factor for the whole appointment. I've had patients that have no problem with anything that may be uncomfortable or painful, but if something tastes bad, they jump out of the chair. So knowing any of these sensitivities beforehand is very, very helpful to make sure you can either avoid them if possible, but oftentimes we can't avoid it. And that comes to the next point, which we'll get to eventually, which is really managing the patient's expectations. So really explaining to the patient before what you're doing, what you will be doing. So if something may taste bad, I'll warn them beforehand that this is not going to taste so good, but don't worry, we're going to clean it out right away. So that way they already know that, it's not a shock that it tasted bad and they don't know what to do about it. They already know that that there's a problem and you're going to take care of it for them. So once you build that trust, it makes it a lot easier to get to that point. Sorry about that. So this patient, actually, you can see this is how he started the process. He didn't want to come in at all. He was just lying down on the floor. For him, he loved bubbles, so we blew some bubbles, and that slowly got him into the room, where originally he wouldn't even walk down the hall towards the room. Eventually, he got into the chair, but he wouldn't let us get the chair back. And then over time, he was even sitting back and ended with a balloon and a high five. So what is really, really important with pediatrics that I find is being flexible. You need to be able to see that you have a goal in mind, but not be too focused on that goal. And again, breaking it into small parts so that even if one part is not working out, you can try to get around that and get to the next part. Because if you look at just the big picture that I need to get them in, get the work done, and get them out, then you're going to end up frustrated oftentimes and not really get anything done. So if you look at it as sort of a small part of the process, which I'm going to show you next, in a patient where the background of this patient is that he was a little 3-year-old who had been to 2 or 3 dentists beforehand. All of the dentists had told his mom that he had to be put to sleep to have his work done because he had a lot of work that needed to be done and he was really, really nervous. And mom did not want to sedate him. So when they came to our office, he was already crying that he didn't want to go to the office because he had already seen multiple dentists and was already scared. But then over time, we kind of worked with him, and at this point, he comes in thrilled to be here. So here's so actually his cleaning was very good in the chair. I'm not going to play the whole video because I don't spend all the time watching videos, but you can see, in this case, being flexible meant sitting and waiting with him because he was too scared to come to the office. And lucky for us, he was scheduled sort of at a quiet time, so he was only one in the waiting room. But in this case, we were able to sort of build a rapport, and he could discuss with me what I needed him to know, and little by little, these are actually x-rays that we got on him, and you can see that he has a lot going on. Over time, we kind of worked our way through from teeth like this all the way to teeth like this with no sedation at any point. And when he finally had all his work done, he was thrilled to have it done. So again, it wasn't a stressful situation for him. It wasn't a fight to get him into the chair. He comes back happily, and he's always asking his mother when he can come back to the dentist. So it's possible to switch a kid who has been terrified of going to the dentist into a kid who's thrilled to go to the dentist if you change the things that scared him in the first place and make it easier for him to understand what's going on versus just come into the office, we're going to do work, and get you out of here. Here's another situation of being flexible. This patient's father actually is a physical therapist, which is definitely helpful because trying to work on a child who's sitting up on the chair makes it not so comfortable for your back. So that's another good tip, is be friends with a physical therapist if you're going to be working like this. But again, doing these type of procedures, again, this is not for actual dental work, this is more for cleaning, but as they learn that it's not scary, they kind of work their way up and get over those fears little by little. You'll gain a trust with them because they see that you have their best interest in mind and that you're doing this to help them. And that's what's really, really important. Here are just some things that I found online in terms of techniques of things not to do. Here the dentist is telling him, here's the deal. If you behave, you get the little drill. If you don't behave, you get the bad drill. So these are things that don't really work for me. There are offices, and there are also ways of, techniques where people have been more aggressive techniques. I find that these days it doesn't work. When I was in residency, I tried to avoid all the negative things and focus more on the positive things. And I do find that definitely helps a lot. So threatening kids just adds to the stress, and it kind of takes away a little of the trust in you, because you don't want them to be scared of you. You want them to trust you so that there is no fear. And if there is something they are scared of, they feel comfortable to come talk to you about it versus just acting out so that they can avoid it. Here's another technique I found online, also not recommended. Here's the way they used to do things in the olden days. So I do feel like there are more ways of doing things now to kind of change the way dentistry is looked at and change the way our patients see it. So again, I'm an adult, I'm a dentist. If I go into an office now that smells like my dentist office smelled like when I was a kid, it stresses me out a lot. For me, you know, going to the dentist as a kid was not a great experience. So I really try to see if we can avoid those specific things that make it a negative experience for my patients. So during the treatment also, we want to sandwich things. We want to start with a fun thing, get them more focused on the fun, more of the excitement, so it's not a big deal, and then slowly get to the treatment. And I'll discuss sort of how to get to the treatment. But when we're doing the treatment, try to keep appointments short. We don't want them in the chair for a long period of time. For me, I'd rather have a patient come back multiple times and do smaller things versus try to do too much in one appointment. Because I have found over time that if you push too much in an appointment, you know, you see that a patient's doing well and then you push a little too much. At that point, if the patient's had enough and they don't want to do anymore, now you're stuck with a tooth that you have to finish treatment on a patient who's already not happy. So trying to kind of gauge while you're doing the work if the patient's doing okay or not is a really important thing. You want to focus on how they're doing, not just focus on the teeth. So you want to be paying attention to your patient's, you know, body movements, to their breathing. A lot of times when we're working with patients, we sing to them, and there are actually studies that show that people who sing together, their heart rhythms even kind of come together. So singing together does kind of calm kids down. It slows their breathing, it slows their heart rate a little bit, and takes away sort of that stress feeling from them. So while we're cleaning their teeth, we try to sing with them. While we're drilling on their teeth, we try to sing with them. And again, with the songs, the stupider, the funnier, the better. You want them to focus more on the fact that their dentist is somebody doing something funny versus somebody who's doing something scary. So this patient, I'm going to play a little of this just so you can see and let you listen to what's going on, and then we'll discuss what.
And after 3 goes 4, and after 4 goes 5. So now we have to put a ring on it. Let's see, should we put it on this finger? Give me 5. Good job. And then we have to count your nose. Is this your nose? No, I know where your nose is. This is your nose. No, where's the nose? You hold this for a minute. Show me where your nose is. Let's see. Nose. Beep, 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 beep. Now look what my nose does. Is there a bird in there? And let me see your fingers again, because I know where your teeth are. Your teeth are over here. Wait, there's no teeth in there. Let me see. I know where your teeth are. Over. Let's see in the ears. Oh, there's the. No, there's no teeth. Where are the teeth? Let's see, maybe the nose. Where are the teeth? Look, you know what? You hold this and you show me where the teeth are. Where are the teeth? Oh, I saw princess teeth. Let me see. Count them.
Show me princess teeth.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Give me 5. Good job. And then we're going to check the upstairs ones. Let me see. Are there any monkeys in there? No. Let me see. What? Wow, they're so pretty. 1, 2, 3, 4, 5.
So from this video, a few important tips. Number 1 is flexibility. So again, this patient was not going to sit on the chair. She was terrified of it. She was only about 2 years old, and she was already really, really scared of going to the dentist. So for her, she was much more comfortable sitting on mom's lap in the back of the room. So we allowed it for this appointment because that was going to kind of build her trust with us and help her stop crying, because initially when she came in, she was crying a lot. Another thing that helps a lot is trying to get them interacting with you. So what we do is we, you know, instead of jumping right in and saying, open your mouth, you know, we pretend that we're looking for her teeth. So I pretend that they're in her hand, pretend they're in her ears, pretend her nose. You know, at this age, it's a funny joke to look for teeth in your nose or your ears. So for her, it's already a little funny that I'm doing that. And it also makes them feel like, hey, this guy doesn't know where it is. I'm going to show them where they are. And that's why she opened her mouth eventually for me, because she was going to be the one who knew where the teeth were and show me. So it went from a situation where she was too scared to even look at the mirror. And again, counting her fingers with the mirror shows her that the mirror is not sharp, it's not pointy. She can hold it, which is always very good. If there's something that you can have them hold, they can feel it and see what it's like, because getting your patients more familiar and more accustomed to the things that you're doing makes it a lot less scary. You know, I try to focus when I have any work done on my teeth, what I'm feeling. And oftentimes, if you don't know what's going into your mouth, it's kind of nerve-wracking. You can't see it, you just feel it, and you don't know if something's gonna be uncomfortable or painful. So showing them a lot before it goes into their mouth definitely helps a lot. So, you know, at the beginning, I could have just given up and say, hey, she's 2 years old, she's crying, we have to get an exam done, you know, she'll lie in mom's lap, we'll hold her mouth open and we'll get it done. But the fact that we spent a little extra time sitting on mom's lap and getting it done this way means that next time she's gonna be a little less scared, and much more cooperative, if we need her to be. This also very important to try to get the best prizes you can get away with and afford, because those are the things they're going to take home and focus on. We have parents tell us 6 months later that the patient is still holding on to that one thing that they got from the dentist office, because for them it's really, really exciting to get that. I have an associate in my office, Dr. Cohn, who actually trained to be a medical clown, and she does amazing balloon animals. So this was kind of a mix between both of us making balloon animals, which is also really definitely helpful. Here's just also a quick video of a patient who had a tooth out, who was a little stressed out.
Colors.
But then,
all right, now you're going to pick one of those colors and put it in here, and give the other two to that so I can't see. Once you put it in, cover it like that. And now I'm going to guess which one you put in. All right, so hold up, put one in, now look in. And then cover it up. Covered?
Okay, so I heard this.
All right.
Okay, I heard this.
Okay, so now, you look. Can I see what's in there? Take a look. Is there any way for me to see what's in it? No, right? So now, give me your hand. You didn't pick blue. Right? You didn't pick pink. You need to pick yellow. Orange, right? All right? Let's see. How did I do that? Is that a good one?
so you can see from here that, sorry about that, that, she's going to go home thinking about the magic trick, not about the extraction as much. So for me, again, magic tricks are not the only important part of it. There's many, many aspects that we want to focus on, but magic tricks are something that are very exciting, very quick, and very visual. So patients focus on it a lot, and for them, that's the exciting thing. It brings an excitement for the next time they come also, because they're going to get to see more magic tricks. So I'm just going to teach you guys a quick magic trick, which you can easily do with a rubber dam. So this is just a black rubber dam. This one is already ripped, but basically if you pull the black rubber dam really, really thin, you can see that it still doesn't rip. So if you look over here, it's going to be a little hard to see, but there's a quarter on top of a little clear plastic container on top of the rubber dam. If you take your hand and you push the quarter, it falls in, but there's no hole. So this trick is really easy to set up if you get a black rubber dam and a little clear plastic container and a rubber band. So you basically take a quarter, and instead of putting it on top of the rubber dam, you actually put it behind it and stretch it through. So I'm just going to do it because it's a little hard to show on camera, but I'll show you afterwards what it looks like. You take a coin and you push it under and just stretch around the quarter and the coin. You can see from the back that it actually goes around it, and it looks like it's on top of it, but it's really under it. And then when you push it, just pushes out the bottom with no hole. So that's just a quick trick that you can do with a rubber dam. At this point, if anybody's still awake, this is actually one of my patients, one of my earlier patients when I first graduated residency, and this is after doing a crown on her. She just fell asleep during the treatment with no sedation because she was that relaxed. And again, if you keep good relationships with your patients, then they keep coming. So she is now a teenager and she's still our patient. So again, you really want to try to keep that time that you spend with your patients positive as much as possible. And it will help your practice in general, because parents will want to bring their kids to a practice where their kids are comfortable and happy being there. This is actually the third office that this same patient has seen me at, because I was working at 2 separate offices beforehand, and they followed me over the years just because, again, it was a positive experience, and it kept being a positive experience. So next are really just tips during treatment. So that's really just kind of building your way to getting to the point where you can get the patient in the chair. It's just important as much as possible to try to keep that as positive as possible. So I generally try to tell people not to force the issue. So if something is a big fuss and the patient's really nervous, I'd much rather schedule them for another day, give them a prize so they realize it's not such a big deal, and then come back and try it another day, versus trying to push it to have it done that day, because then you oftentimes will lose more than you're going to gain. So really, I'd rather slow things down at the beginning, because over time you realize that you'll save a lot more time, even if at the beginning it takes much more time than you expect. So for younger patients, if at the first visit they're not happy, we don't do a cleaning on them. We just discuss with the parents our findings and send them home with a prize and a magic trick. So that way, they realized it was a short appointment. I was scared about it, but it really wasn't anything to be scared about. And then the next time, they're usually much, much happier. So number one is you want to manage expectations. And this is for the parents and for the patient when you're about to start treatment. So that starts with really earning their trust and gaining their trust, and making them sort of part of the process versus you being the dentist who's just doing everything to them. Work with them in the process so that it's a team effort. Oftentimes I'll tell my patients that, I'm here to help you, but I need your help to be able to help you. So together we'll be able to kind of make these things work. So for me, it's very important to have that trust built between us before we do anything at all, because if there is no trust, then it's much scarier for the patient because they don't know that you're there for their good. As soon as they have that idea that you're there to help them, it makes life easier. So I generally recommend sort of like a raise your hand situation when we're doing work, in that if you raise your hand, we stop what we're doing. So anytime my patient during treatment raises their hand, I stop on the spot if it's a safe time to stop. And it's even if they do it 10 times, because I want them to know that they can trust me, that I told them, when you raise your hand, I'm going to stop, and then they stop, and then we stop. So it's really important to keep to that. I also find that it's very important, sometimes we kind of lose perspective because we expect children to act like children. So we expect sometimes, behaviors that we wouldn't expect from an adult. We say, hey, he's just acting like a child. I know that I gave him enough to be numb and he's still complaining. He's just complaining because he's a child. But I find that it's very, very important to not disregard a patient who's telling you that something's uncomfortable, even though you think that they shouldn't be uncomfortable. Because two things. Number one, they may actually be uncomfortable. And number two, what we ourselves consider uncomfortable may not be what they consider uncomfortable, and what they consider uncomfortable may not be what we consider uncomfortable. For a patient, sitting there with their mouth open for a while is very uncomfortable oftentimes. So it's just very important to have a dialogue going on, even though it's hard to talk to somebody while they have their mouth open with tools in it. It's important to have the possibility of a patient stopping what's going on to discuss with you what their concerns are. Especially if patients are in pain when they first come in, oftentimes as numb as we think they are, if their nerve is inflamed, they may not be as numb as we think they are. So they may actually need more anesthetic than we think at times. Again, you always have to make sure that you're following dosing rules, but it's important to pay attention to a fact that if a patient seems to be in pain, they may actually be in pain. So that's something very, very important to focus on. The next step is Tell, Show, Do, which is sort of the cornerstone of all pediatric dentistry, is telling the patient what you're going to do, show them what you're going to do, and then actually do it. You don't want to just jump into stuff without them knowing. Modeling is another important one. I'll show you some pictures of that, where basically a patient who's nervous can see what's going on another patient, and we'll actually sometimes have it even not with family members. If we have a patient in one room who's very, very nervous and a patient in another room doing great, well, oftentimes after asking the parents and the patient's permission, we'll have the nervous patient watch what's going on with the other patient so they can see that it's not so scary. And then the last thing is creative wording. How we say things and also what we say is very, very important. In our office, we don't use the word hurt, we don't use the word shot, we don't use the word drill. We switch those words around because we definitely want to acknowledge that those things exist, but we want it to be in a less scary fashion. So we'll get to exactly how we do that. Here's a situation of Tell, Show, Do. Just keep jumping ahead. You can see this patient was nervous, so he became the dentist. He gave him a help.
See that? Is it one time? Let go.
We make a little cavity on a fake tooth with a mark, and he gets to drill out the cavity so he can see what's going on.
Right.
So this brings it sort of out of his own mouth. So he gets to see it from a different perspective and see that, hey, I have a tooth, the tooth has a problem. We use this little tool that doesn't look as scary when you're holding it. And it
better.
out what we want to
Now it's all dusty. What do we do with the dust?
When they think themselves and they see what's going on, it makes it a lot easier.
Good to do this.
Scarier. We have modeling in different ways. I don't always recommend having a patient kind of sitting on the other patient, but this sibling wanted to see really close what was going on. So she just sat there as the hygienist was cleaning teeth and watched what was going on with her brother. Here were two siblings that both wanted to watch the same TV. We do have TVs over the chair so kids can watch movies and really whatever they want to watch. So they sat next to each other. In this case, a sibling, this is Dr. Cohn. She was, the patient's sister was really, really nervous, so she got to dress up like a dentist and sit on Dr. Cohn's lap. And again, you can see mom on the side videoing. This is also very good for your practice in general, because when parents see how well you treat their patient, their children, they want to share it with others, and that gets the name out. So I did see one of the questions that was asked earlier, if I have parents in the room. As a rule, almost always we have parents in the room. In residency, oftentimes we're taught not to have the parents in the room, and there definitely is a good point to that, because if the parent is out of the room, it's easier for the patient to focus their discussions with you versus trying to focus back on their parent. But I find from my comfort level, I like having parents in the room because we can have them as part of the team. There are times where if a parent is interacting too much and it's getting in the way, that we'll nicely ask the parent if they can allow us to do the talking. And there are times where we ask the parent to just stand right outside the room so that they can see what's going on. They don't have to be nervous about it, but that way the patient sort of focuses more on us. So those are things that will definitely help as well. Here's another sibling becoming the dentist. So these really help, and we do it very often. Here's a case where we didn't have another model, so I was the model, and I've had patients that didn't want the fluoride treatment, and I allow them to do the fluoride treatment on me, and then they see that it's not scary, and then we do it on them. So those are different things that you can incorporate that definitely will help a lot. Now, in terms of creative wording, I find that this is a very, very important part of what we do, because when you speak to an adult, you say things how you mean them, and they understand what you're saying, and the conversation goes on. But the problem is that with a patient that's younger, they'll pick out of that sentence the words that they really get nervous about, and they'll focus more on those words. So if you say, "Don't worry, this is not going to hurt," they just heard the word "hurt" in there, and that's already going to make them nervous. When they go try on new shoes, mom doesn't say, "Don't worry, it's not going to hurt." So soon, even though you're saying it's not going to hurt, if you say it like that, they're going to already sort of get on edge a little bit and be a little more nervous. So it's important to try to change the way you word things. So I try not to use the word pain or hurt, but I don't want them to think that it's not possible. So I always tell them that it can bother or be uncomfortable, which again, hurt or pain will be uncomfortable. So that way, if anything bothers or is uncomfortable, they should let me know. But we don't say if anything hurts, because we don't want them to think that it will. And we try our best to make sure that it doesn't hurt. And that's, an important aspect. We don't use the word drill because, again, it can be a scary sounding thing. So we call it either a fire engine because it's noisy, or the bumpy thing because it's a little bumpy. With a shot, we call it either a sleepy juice or dripping something near your tooth. But again, we don't want to call it a shot because they already have an association with the shots that they get from the pediatrician. The topical anesthetic, we call it jelly. The fillings, we call either a princess polish or a Superman polish. So all these different ways of calling things definitely help. And we've even had patients that as soon as you said, "We're going to brush your teeth," they start crying. But if we say, "We're going to polish your teeth," then they're fine with it. So it's important to try to be, again, flexible in figuring out ways to word things so that they don't sound as scary. At the same time, you don't want to lie to a patient and tell them, "No, there's no way it's going to hurt," because we know that it's a possibility. So you want to be honest with them because you want to keep that trust, but you want to explain things in a way that they understand it without it being very scary. So during treatment, what's really important is make sure it really doesn't hurt. So I do feel like making sure they're adequately numbed is really, really important. Not often do we numb. I mean, there's oftentimes that we don't numb, but there's, you need to make sure that what you're doing, you're confident is not causing pain to the best of your ability. Don't say it's not going to hurt because it actually may hurt, but just explain that if something is uncomfortable, you'll fix that for them. And again, being flexible is always very important, because if you're starting something and it doesn't seem to be working out, you need to have sort of a plan B. You have to have another option of what you're going to do, because you don't want it to be that your only other option is now to hold down a kid who's maybe fighting and kicking and screaming and finish the treatment anyway. So it's really important when you're doing something. I like to have a lot of different filling materials in my office so that if I want to do a composite, but I can't get good isolation because the patient doesn't want to keep their mouth open as long, I can use either, a glass ionomer or something to be able to fill the tooth without having to worry about isolation as much, because you don't want to compromise your treatment, but you also don't want to compromise your patient. So it's really important to just have that second plan of what you may be able to do. And one more thing is always more magic tricks. So if you can stop in the middle, if a patient is nervous, and show them something funny. For us, a lot of times, I think we have in some of the videos where we press their nose and we make a bird sound. I've had dentists ask me how I make that bird sound. I have no idea. It's just something that I learned over time. But there's a million other things that you can do that can help as well. And here's just another aspect of being flexible. There's a patient who had gone to the dentist before and was really nervous, wouldn't even come into the room. So we actually started his filling with him standing next to me.
No, I know.
Out the doorway of the room, just standing up behind me. But he was too scared. As soon as we tried to get him to sit in the chair, he just ran away. So standing up, he was fine with it. And
Let me try again.
Think
I can get it?
Let me try it. He realized, hey, this is not so scary. And if it's not so scary, then maybe the other part is not so scary. And, little by little, we got him to sit in the chair, and he was able to.
He's big, and it stops the same way. Anytime you need a break, you just raise your hand. Ready?
Doing everything typically. So again, it definitely does take more time up front, but it was a lot easier.
You are so good. Should I tell your mom that you should be a dentist when you get bigger and you need help me? What do you think? You're going to be my helper? Then it's not. How did you do that?
As soon as you raise your hand, it stops, and that just continues that trust. Here's just another case. I'm just going to run through it quickly.
If it's too bumpy, just pick up the squishy key and I'll stop.
Multiple times more.
Pick up the squishy key. Let's do it. Oh, you did it again. All right, now we're doing the next one. It's going to be a little tickly.
I'm just going to run into just some of the more recent questions, and I'll try to answer all of them at the end and just see if they're related to what I'm doing now. I'm just going to go to the end of the questions, and we'll work our way afterwards.
Sorry to interrupt you, Dr. Simchi.
Sure.
But a lot are saying that they can't hear you when the voice, when the video is playing. And
I'm sorry about that.
Okay.
Got it. Okay, so what I'm just going to discuss what I just showed in the video, but in the future, I don't think there's that many videos anyway. So thanks for letting me know. So with the last video, I'll just go back to it and just so you can see what it is without it playing. So this patient actually had been to a dentist before and was very, very nervous, and he wouldn't even really consider coming to the room. He walked up to the room, but as soon as we tried to convince him to sit in the chair, it just wasn't going to happen. So in his case, we actually started the filling outside of the room, sort of standing next to the door of the room. And in the video, you can see, we play around with him, make a lot of jokes. When he raises his hand, it stops so that he knows that happens, and made it more of a fun situation. And because for him it was a fun situation, eventually he got into the chair and we were able to complete the treatment like this. So what I was saying before also is that even though, again, it does take more time to do things like this, once he's in the chair, everything is much more quick and efficient because he's already not nervous. So we don't have to worry about working on a patient who's crying or moving or jumping or scared because he's already calmly sitting in the chair. And that was the same thing for this next patient, and I'm just going to play the video for a second so you can just see what she does.
If it's too bumpy, just pick up those squishy teeth and I'll stop. One. Pick up the squishy teeth. Let's do it.
So in her case also, I actually told her to raise her hand. So oftentimes we'll tell a patient if something's uncomfortable, raise your hand and I'll stop. But oftentimes, and most of the time, it's not uncomfortable, but we want them to gain that trust. So if I find that I'm starting something and they're not raising their hand, I'll actually stop what I'm doing and say, okay, raise your hand now so that we can see if it works. So that teaches them that, I told you if you raise your hand, it's going to stop. You raise your hand, it's going to stop. So that for me also is a very, very important thing. The next thing, which is this slide, is choices. Kids like having choices. So you can't give them the choice of something that you don't accept. So you can't tell them, hey, do you want to fix your tooth or do you not want to fix your tooth? But you can say, do you want to fix your tooth for 20 seconds or do you want to fix your tooth for 10 seconds? And what that does is it gives them power and it gives them sort of the ability to control the situation a little bit. When you're at the dentist and you're lying back and your mouth is open and things are being done in your mouth, you don't really have control over the situation. So that hand raising trick of raising your hand when you want things to stop, it gives them control of a situation that they don't really have control on. Another thing that gives them control is when you give them choices. So, I'll tell them first, do you want to check your nose or do you want to check your teeth? So if they want to check their nose first, then we check their nose first, but then the second part is checking your teeth, and they have already chosen that the nose is first and the teeth is second. So then they're more likely to accept that. And again, if you make those choices something funny, then they'll laugh at it, and the situation is not sort of a clinical, hey, we're getting in and we're doing what we want to do. It's more of, hey, this is a funny joke and we're going to play around with that joke. So we'll ask them if you want to brush your teeth or brush your hair. And then the other things are options that, when we're working on a tooth and I'm drilling on a tooth, I try to do things in really, really quick bursts. I don't try to do things for a long period of time. So if I'm prepping with a handpiece, I'm not spending a full minute drilling. I'm spending just a few seconds at a time, stopping, doing it again and stopping. And what that does again is it shows them that it's not something they're stuck in for a long period of time. It's something short, easy, they're getting it done and that's it. So we'll ask them, if I need to do something for 5 more seconds, I'll ask them, do you want to do it for 10 seconds or do you want to do it for 5 seconds? And typically they'll pick the shorter amount of time. So for me, always have the shorter amount of time to be the time that you need it to be. So if I need to do something for 10 seconds, I'll ask them if they want to do it for 20 seconds or 10 seconds. And most of the time I'll ask them if they want to do it for 10 seconds, 20 seconds, or a million seconds. Because again, you want to have a dumb joke in there as much as possible. So, you know, the parents will look at you funny because you're dumb, you know, your jokes are a little strange to them. But for the kids especially, the jokes are exciting, and it's what helps them kind of keep going through the process. Another thing that I find is, again, perception of how they see things. So one thing that I find that I didn't really put any slides in, but I'm remembering now, is for gagging. A lot of patients have a hard time. They're not scared of pain. They're not scared of taste, but they're scared that they're going to throw up, because when you put a lot of things in their mouth, they just feel like they can't breathe. So gagging is mostly perception. It's really what they're feeling in their mind. So it's really important to be able to explain to them that they're not going to throw up. And what I generally do in cases like that is I'll give them a mirror so they can see what's going on, and see that things are not as far back in their throat as they feel. So for x-rays, if a patient has a hard time taking an x-ray, I'll tell them, don't worry, we're going to switch to an easier film. And I go behind the patient, I open a drawer and I close a drawer, and I use the exact same film that I used beforehand. And 90% of the time, they have no problem with the new film because it's the easier film, even though it's the exact same film. So trying to kind of guide their perception of what it is definitely very, very helpful as well. So here's just a quick case that when I was in residency, this is a patient that came in that had been to a dentist before and was adamant that he wanted to have laughing gas. And unfortunately that day we were out of laughing gas because the tanks hadn't arrived. So for this patient, we put the laughing gas on him and we played with all the knobs. And as soon as we sort of pretended we had the laughing gas, he did beautifully and he was comfortable and he was happy the entire time. But here's the real picture, because in reality, we didn't have any laughing gas. So he was just sitting there with a thing on his nose, breathing in just room air through those tubes. But he was convinced that the laughing gas was working, and because he was convinced it was working. So you need to work with your patient's perception as well. So I do find that that helps a lot. So that goes back to, once again, being flexible. So I'm going to actually play the next video, and then after the video, because you couldn't hear me, I'll explain what was going on in it.
I hold this one. Hang on, but you have to hold this one for me. Hold it. Don't try it. 1 second. Hang on, I'm going to stick on my nose. Hang on, let me see. Do you have it on your nose or my nose? Where is it? My nose? Okay. Now you hold it. Where is it? Can you throw it to me? Oh. And now 1 second. There's another one.
So I'm just going to stop that for now, just to say, when she came in, she was already crying. She wasn't interested in talking to me at all. She was only 2 years old, and there was really not much interaction at all. Even when I was trying to show her magic tricks in the waiting room, she was already crying. So in this case, mom put her on her lap so she was a little more comfortable. And you can see that although she was crying at the beginning, she paid attention to the magic trick. And that light magic trick is one of my favorites because you can't really avoid it. Even a patient who doesn't want to look at you and doesn't want to talk to you sees the light, and they notice that it came from nowhere. So if you can sort of catch their eye and make them sort of interested in what you're doing, even if they're not interested in what you're saying, that can work. And you can see that she sort of was crying and laughing at the same time, because to her it was funny, because the light was coming out of her nose and coming out of my nose, and it was just an exciting situation, and we weren't looking at her teeth at all. This next video that I'm going to play is about a minute later, right after that.
Here we go. Which one's first? Upstairs ones or down? Oh, nose first. What does mine do? All right, now teeth. Let's see ABCs. A, C, D.
So you can see that she went from not being okay with anything, and again, she had a choice if she wanted to check her teeth first or her nose first, and because she had that choice, it gave her that feeling of confidence to be able to say, okay, this is what I'm picking, and since I listened to her, it gives her that feeling of power and control over the situation, and she finished the appointment, you know, happy and laughing the entire time and asking mom if she can come back. So those things will get you to the point of doing work. Now, the lecture is almost over, I think. I'm just going to show you a few more things just about planning for the operative part, but I'm not going to discuss a lot of options for operative, because that I'll make into a lecture for another day. But what's really important is having a plan. This is a patient who came to me with these x-rays. You can see on the patient's top right, he had amalgams done. On the front teeth, there was some kind of composite done that was mostly missing. But what the problem is that the dentist went into the situation without a plan of how they were going to finish the situation. Because again, if there's one tooth to do, then you can finish one tooth and then the patient's done. But you always need to know that when you're doing one operative appointment and they need more work, you're going to have to keep your focus on the fact that they're going to need more work to do. And if they're going to need more work to do, you need to try to make that appointment as easy and as comfortable as possible so that they'll come back next time. Unfortunately, in his previous dentist's office, they were able to finish, you know, a little bit of work, but then the patient was totally uncooperative, and he was only 4 years old at the time. So this is how he ended up at the end. You can tell he was obviously very, very high risk, but this was done all with, at most, laughing gas. There was no, we don't do any other kind of sedations in the office, so it's just local anesthetic and nitrous oxide. He wasn't papoosed, he wasn't crying, he worked through the all this work, got it done, and still came back happily. So it's definitely possible, but it's really, really important to have a plan when doing that. I'm going to skip some of this so that way, this is just, you know, some of the videos of how we do, for instance, an injection and keep it less scary. So I'll let it play for a little while just so you can hear a little bit of what we do, and then I'll discuss a little bit of what I did.
So you just stay open. I'm going to tell you where to put your mouth. If anything bothers you, just raise his hand like this. Just don't punch me in the nose. All right, I'm going to hold your cheek to the side. It's going to feel a little cold in your chin, a little cold in your lip, and then it's going to feel pretty cold next to your tooth. If anything bothers you, raise your nose. No. And remember, open super wide and bite down all the way. Good job. Now you can feel a little cold next to your tooth, and now you have to listen to hear if you hear anything sleeping. You hear anything sleeping yet? Is that you?
So you can see from him, you know, that he was a little nervous at the beginning. He hadn't been numb before, and he was nervous about what was going to happen. So again, what I generally do is try to explain to them, and that's why I was telling them that it's going to feel a little cold, because even if they feel something a little uncomfortable, if they understand it more as a very cold sensation versus a painful sensation, it makes it a lot easier for them to process that. So I generally will start with, you know, a very, very strong topical anesthetic. So that way, as much as possible, we don't feel the injection. A very important tip for doing an injection on a child is very slow injection. The slower you go, the better it is, because the pain is usually not from the actual injection. It's from fast anesthetic, like the anesthetic, you know, quickly going into the tissue and pulling that tissue away from the bone. So slow is really important. Distraction is really important, which is why we make those funny sounds. So he can hear his tooth snoring. You want to try to talk a lot, make a lot of funny jokes, so he's distracted from what you're actually doing. Also, shaking the cheek definitely helps a lot. A lot of people know that technique, but typically the brain can't process two sensations well at the same time. So if you vibrate the cheek while you're injecting, it's less likely that they're going to feel any pain. So those are also very, very important techniques for this. So in terms of what you need overall to succeed for operative, it's really important to have a plan. You want to get a good history so you know your patient beforehand. You want to establish, you know, care for the patient and trust with the patient. Really important to avoid pain. You want predictable and efficient treatment, which would be a lecture for another day. And then rubber dam is because I was going to discuss that at a different point. So, I mean, at this point, that's what I feel like is sort of the important parts of behavior management. I'm going to go through the questions now, if that's okay, I guess, and I'll run through them and try to answer them as well as I can. So, I'm sorry?
Thank you, Dr. Simchi, for your informative lecture and all your tips and tricks. We would just like to announce that we have an activity that we'd like to share with you guys. The activity is share a photo or a video of your own personal tips and tricks on your Instagram or Twitter and mention us. We would love to repost it in our Instagram story and Twitter feed. Now we can go for the question and answer, Dr. Simchi, at the Q&A section.
Sure. So the question from Harim, how do you handle patients who have already seen you like they are from your family? I try to treat every patient as I would treat my own patients and my own family. So if it's not something that I would do on my own family, it's not something I would do on my patients. So that's an important thing to remember, is that we're here as people trying to help others. So it's sometimes difficult when you own a practice, you know, you're kind of focused on the business of dentistry and, you know, you need to produce as much money as you can and try to get in as many patients as possible. But really, as a pediatric dentist, I find that our real reality is that what we really need to do is try to make sure that our patients are happy and our patients are comfortable. And that's really what we really want to answer. I mean, what we really want to sort of work towards. In terms of where I learn my magic tricks, again, I don't have any specific area. I learn them all over the place. With patients, the question about patients with autism, generally, there is no perfect answer for that because autism is a spectrum and it's a very wide spectrum. So what happens is, for me at least, is it really is a case by case. There are some autistic patients who are perfectly fine at dentists and are happier than a patient with no medical issues, and there are some patients that can't do anything. What I do find for patients with autism is it's very, very important to find out what their specific concern or sensitivity is. That's something that's going to be really, really important because autistic patients oftentimes will sense things more than we will. So sometimes an annoying sound to us is a little annoying. For them, they can't even tolerate it at all. So it's important to try to find out what their specific sensitivities are. They also do much better with routine. So you want to try to work up a routine that's the same all the time, but it really is a case-by-case basis, and it's really a patient-by-patient basis because of the wide range. This question with the situation of personal protective equipment and patients that are nervous, it's a very difficult situation because I like not having any of my personal protective equipment on when I meet a patient, and now we need to have it on if we meet a patient. So as much as possible, be as fun as possible and have as many prizes to kind of counteract it. You can also, with a regular face mask, they do sell face masks with funny faces, or you can even use a marker and make a face on it. I think that could be helpful. Printing out, I've seen in some hospitals where they print out a picture of their own face and put it on their protective equipment, so that way you can see what's going on, can be helpful, but it's pretty difficult. In terms of young children with early childhood caries or severe early childhood child caries, I don't have the time really to go into all the things that can be done. We do use a lot of glass ionomers and a lot of silver fluoride to try to stop that process. Even though I don't sedate patients in the office, there are times where the only safe option for a patient would be sedation, but for me, it's the last option. So the last time I went to the operating room was 2 years ago. Explaining to a parent when a child goes hysteric, the way to explain it to a parent really is explaining beforehand. It's really important to have the parent prepared, which was what I was saying about that you're dealing with 2 patients. You really want to have the parent prepared beforehand to say, hey, if your child does get upset, this is what we're going to do, so they already know, what's going on there. All right, next question. If stuffed animals are used, are there concerns about infection control? So yes, so usually as much as possible, the stuffed animals that are used in our offices, are stuffed animals that patients bring by themselves. The ones that we have in the office, we usually keep on the desk away from patients. If they're touched by patients, then we want them to be cleaned beforehand. But most of the ones that they're holding in terms of stuffed animals, which is why we don't use it that often, are ones that they bring from home by themselves. The next question was, how much time do you allocate for a first-time visit for a younger patient below 5 years old? Generally about a half-hour appointment for a new patient. Let's see. I'm just going to scroll down. Do you ever have parents complaining about the time spent and the cost for the meet and greet and appointment? Sometimes for the time, but not for the cost, because we don't charge for the meet and greet appointment. Again, I said sometimes the art of dentistry doesn't mix the business of dentistry. For me, the more important thing is the art of dentistry and keeping my patient happy. So we don't typically charge for meet and greet appointments. We only charge for things that we do. So if we don't do a cleaning or we don't do anything, we don't charge for it. So in terms of the time, parents do complain sometimes because they do have to take off work. But how I explain it to them is I explain to them that the reason we are good at what we do is because this is what we do. So the reason that patients are coming to us is because we have figured out what works for the parents and for the patients, and this is what works for them. So in terms of if we keep the appointment short, then the settings increase for which patients are a bit hesitant. We have full mouth rehabilitation. So I didn't really understand that question, so I'm just going to go to the next one. If the patient is not willing to cooperate, when do you stop trying? Unfortunately, there's no perfect answer for that. It really depends on why I feel like they're not cooperating and if I feel like I'll be able to get through to them. If I do feel like I'll be able to get through to them, then I keep working at it, or we reappoint to a time, meaning if it may be later in the day and the patient is tired, we may make an appointment for the morning. But it really is a case-by-case basis. Are you able to do a full exam with the child sitting on the mom's lap at the back of the room? Yes, we've done exams on patients sitting on the floor. We've done exams on patients sitting on their parents. We've done exams in every possibility. And generally, we don't charge for the exam if we don't complete the exam. But if we can't complete it, then we send them home, and then we only charge for when we do things. So we don't charge just for trying. How do you manage parents trying to rush treatment? Again, for me, the sort of answer that I give when a parent is trying to rush treatment is I explain to them that the reason that our practice is good at what we do is because we do things in a way that we've worked for years to figure out how it works. And we explain to them very nicely that, you know, if we want to keep our patient happy and healthy, then we need to do things the way that we expect will work out. So that's generally what we tell parents, and typically that works very well. Tips of painless anesthesia. I'm probably going to keep that for another lecture just because it takes a little while longer. But the most important tip that I would say just quickly is preparing the patient beforehand and doing things slowly. Choice of drugs post-treatment. I don't prescribe any drugs post-treatment. If they do have any more complicated work or more invasive work, then sometimes we'll recommend ibuprofen, but nothing more than that ever. Do I discuss treatment planning pros and cons in front of patients? Most of the time it's done behind the patient, and because we have a TV on top of the patient, we don't separate the parents specifically away from the children, but generally the kids are watching videos, and even when I'm talking to the parents, I use the same type of language to keep things not scary sounding. So we don't say we're going to pull the child's tooth, we tell the parent that we're going to help the child's tooth out. So we generally will word it in a way that even if the parent is listening close to the child is not going to get nervous about it. Because again, we also don't want the parent to be nervous about it. Next question is, how do you deal with situations of giving local anesthetic? Again, that's a long answer, but being scared of the needle, the one thing that I can do with my right hand, I'm a lefty, I can inject with either hand. So generally my patients don't know that they're going to get a needle. So I try my hardest, especially for the younger children for sure. As children get older and they know they're going to get a needle, then I'll discuss it more with them, and sometimes I'll even show it to them. But again, that's one of the things that takes a lot more time to answer, and also as a case-by-case basis, it depends on the kid. Next question, the Tweety bird sound. That's all it is. I have no idea how I do it, and it's just something that I learned how to do when I was younger, and it definitely, thank God, helps me a lot in my job. Sometimes even after local anesthetic, kids don't like the sensation of drilling and start throwing tantrums. That's definitely a possibility. And that's, again, why preparing the patient beforehand is super, super important. Meaning if you don't tell them they're going to be numb and what the feelings are going to feel like, then they definitely can get nervous. And oftentimes it's not even the sensation of the drilling, it's just a numb feeling. Personally, I hate being numb, so I definitely understand it. And that just takes extra time preparing them beforehand to explain what the feelings are going to be like. Now, sometimes kids still don't like drilling, and with that is why I said in the lecture, it's important to have a plan B. I've done full fillings and full drilling and filling with a low-speed drill because they liked it more than the high-speed. And again, when I do choices, I give the patient oftentimes the choice, did you like this one better or did you like this one better? And then I'll finish it with either the high-speed or low-speed, whichever one they like better. There are times where, again, the only option at that point of the plan B, if you can't get away with drilling, luckily, again, as you get more experience with it, there won't be a lot of those times. But if you can't, then we have options of temporary fillings and silver fluoride to help buy time. I've been with doctors who say that if a child starts kicking and screaming and you let them go, they will continuously do that to get away. What is my take on that? My take on that is I definitely understand that. At the same time, I do feel like you don't want to make it about not letting them get away with something. So again, children do learn that if they do something and they get away with it, they'll do it again. But you want to try to figure out why they're doing it in the first place, and see if you can kind of control the situation away from that instead versus just forcing the issue. So if that's happening, generally the child is going to be very, very nervous and very scared. Or in pain, you want to try to see if you can bring the focus onto what's causing it. And sometimes you can't. And sometimes, you just have to decide if you're going to stop or not. But I do feel like for my way of doing things, I'd much rather my patient trust me to know that they're not having a good time. I'm going to stop and give them a break versus saying, you know what, they're going to learn that they don't have to do it if I allow them to get away with it. So I lean towards not saying they're going to feel like they're going to get away with it, and more towards they're going to trust me more because I'm taking their feelings into consideration. And again, it doesn't always work, and nothing I do always works, Everything, again, is using your options and the tools that you have to try to make everything work as well as possible. Other question was, if a patient asks if it will hurt, how do I answer? I tell them I hope not. That's what I always tell them. If they say, is it going to hurt? I say, I hope not. I'm going to try my hardest to make sure that everything I do shouldn't hurt, but it's possible. And then I tell them that because it's possible, you have the control of stopping anything if anything's uncomfortable, and you just raise your hand. And as soon as you raise your hand, I'll stop on the spot. So I tell them that I'm going to test out things on you so you can see what it feels like, so you can see that it shouldn't hurt, but if anything's uncomfortable, you let me know right away. All right, the next question was many times, let me see. The portable handpiece that I'm using is called a Micromax. I found it online. It's, I think, an American company, but it's called a Micromax, and it comes with different heads. So one head you can attach a Profi brush to, and one you can attach a slow speed handpiece tip to. It doesn't prep very fast. It's a very, very slow process. The major advantage is that it's not scary looking, it's not noisy, and it has the possibility of slowing down the speed. So you can make it really, really slow, so you can try it on their finger, or you can have them try it, so they can see that it's not so scary. For pedo practice, what steps do you take in your new patient or intake forms? Really just those questions that I discussed earlier. Getting as much of those questions answered and as much information gives us a lot more to go with. It also helps to know if they've been to a dentist before and how the experience has been. So all the previous history and everything you can know about the patient in this situation is definitely helpful. What do you do if a patient is fine, allows you to start, but they start crying when you enter the pulp? So if they ever get upset when I get close to a pulp or enter a pulp, my first feeling is that they're in pain. I don't assume that they suddenly decided that they just had enough, because I know that as much as we think they're numb, sometimes they're not as numb. So what I do is I stop on the spot and I ask them what's going on so that they can tell me if there's pain. And in terms of how do you finish the work, sometimes you can't. Sometimes you need to just put a temporary filling material in, like an antibiotic type of material into the tooth and put a temporary filling or a sedative filling. But most of the time you can finish. And again, this wasn't a technique I was going to discuss in this lecture, but just quickly, the technique that I do, I don't know of any studies, I kind of made it up. What I do is I take a tiny little cotton pellet, I soak it in articaine, and I press it over that exposure so that it sort of slowly diffuses into the tooth. I give that a few minutes, and then I do an intropulpal. If you go straight to an intropulpal, it's very, very painful. And you'll, in my opinion at least, you'll almost never get away with an intropulpal on a painful tooth on a patient and be able to finish treatment. But if you can sort of superficially numb it with that cotton pellet soaked with the articaine sitting on it, then slowly do an intropulpal instead of a lot of pressure and work your way in, most of the time you can get that pulp numb enough and finish it. What do you do if a patient comes for an emergency situation for the first time? If it's an emergency situation and I can buy time, then I buy time. So meaning if I can put them on antibiotics to get them out of pain, then I'll do that to try to buy time in a lot of situations. But there are times, and those are the few times where we will actually do treatment for the first time. But again, we have to work a lot harder to try to keep it as comfortable as possible because these patients don't know us at that point. How do you handle parents' expectations when it's not what the patient can handle? I think because of what we do already, parents already understand, and very often we're the third or fourth or fifth dental office that they've been to, so they already kind of know what's going on with their child. So their expectations are already sort of that it may not happen, and also a lot of explaining beforehand. All the pre-preparation is the most important thing, and we explain to the parents that, again, we're going to try our hardest, but there are times that it can't be done. So they already know going in that that's a possibility. How do you move from the magic trick and talking to actual treatment? So it's just a continuous process. We do a magic trick, we discuss things. After the magic trick, we'll discuss what we're going to do in the treatment, and then we oftentimes will practice it on their finger or on a fake tooth, and then work our way towards it. Hello.
Yeah, hello. We would like to thank you again, Doctor, for this wonderful, well informative lecture. We're really honored and pleased to have you here with us today.
Oh, my pleasure.
I'm a really big fan of you, actually.
Thank you.
And thank you all for attending our seminar, our webinar today. And we hope to see you in our next sessions, inshallah.
All right.
And yeah, goodbye.
All right. Thank you very much.
Thank you.